and welcome back to another video of Medic Notes. This video will be on asthma. Asthma is defined as recurrent episodes of dyspnea, cough and wheezing, which is caused by reversible airway obstruction. There are three factors that contribute to airway narrowing, which are bronchial muscle contraction, triggered by a variety of stimuli, mucosal swelling or inflammation, which is caused by mast cell and basophil degranulation, resulting in the release of inflammatory mediators, and increased mucus production. The symptoms of asthma include intermittent dyspnea, wheezing, coughing, which is often nocturnal cough, and sometimes there's sputum production. Patient might complain of chest tightness as well during the shortness of breath. Wheezing is a whistle-like sound that is heard when the patient is having shortness of breath. And the symptoms of asthma are characterized by diurnal variation, where the symptoms or the peak flow may vary over the day, and there will be marked morning dipping of peak flow seen. Some of the precipitants of asthma include cold weather, exercise, allergens such as dust, mites, pollens, or even pet fur, smoking, either if the patient smokes themselves or passive smoking also, infection, especially lung infection, and some medications such as NSAIDs and beta blockers can precipitate asthma as well. Should ask whether the patient has any history of atopic disease such as eczema, which is a skin disease, allergic rhinitis, ask whether they always sneeze and have flu symptoms, especially during morning, and conjunctivitis, where they may complain of red eyes. Also ask about the family history of any atopy or family history of asthma as well. On physical examination, the signs that we can look out for is look at the vital signs, expect to be tachypnic, hear for audible wheezing. On inspection of the chest, look for any use of accessory respiratory muscles. On inspection as well, we can also see a hyperinflated chest. On percussion, there will be hyperresonant percussion, and we can auscultate the lung, expect to hear reduced air entry. These are the common signs of asthma, whereas for life-threatening attack, the patient may have silent chest, confusion, cyanosis, bradycardia as well. This is for severe asthma. For investigations, we can do peak expiratory flow for the acute attack, sputum culture if there is any, arterial blood gas analysis, usually shows a normal or slightly low PaO2, but the PaCO2 will be low since there is hyperventilation. For chest X-ray, look for signs of hyperinflation of the lungs. Lung spirometry will show an obstructive pattern. And we can also do skin prick tests to test for allergens. So after doing the spirometry, we can do a steroid or beta agonist trial, and usually there will be a more than 15% improvement in the FEV1 after the trial if it is asthma. This is to differentiate between asthma and other obstructive diseases such as COPD. For treatment, we can divide the treatment into acute asthma attack and also chronic asthma. So for acute asthma attack, when the patient presents in the emergency department, we assess the severity of attack by checking the peak expiratory flow, the ability to speak, the respiratory rate, pulse rate, and oxygen saturation as well. The immediate treatment would to be give supplemental oxygen to maintain the saturation around 94 to 98%. We can give salbutamol or terbutaline nebulized with oxygen. And if the asthma is severe or life-threatening, we can add in ipratropium as well. Then we reassess the patient's condition every 15 minutes. We monitor the vital signs, and if the patient is not improving, we can refer to ICU to consider for ventilatory support or increase of the medical therapy, for example, aminophylline, or even IV salbutamol. If the patient's condition improves within 15 to 30 minutes, we can then continue the nebulized salbutamol every 4 to 6 hours. And if the peak expiratory flow is more than 75% 1 hour after the initial treatment, we can consider discharge with outpatient follow-up and also give prednisolone for around 5 to 7 days. This is for acute asthma attack. Whereas for chronic asthma management. We advise the patient to quit smoking if there are smokers. We also educate them to avoid the precipitants in their house. For example, avoid people who are smoking, and also clean their bed sheets regularly or remove any pets from their house that could have precipitated their asthma. Provide a written action plan so they know what to do if they have another attack. And some of the medications that we can give for chronic asthma depends on the patient's condition, but the medications include beta agonists, where there are short-acting and long-acting. The short-acting ones would be salbutamol, and long-acting ones will be salmeterol and formoterol. Corticosteroids like beclomethasone or oral prednisolone, amylophenolate, anticholinergics like ipratropium and tiotropium, leukotriene receptor antagonists like montelukast and zafirlukast, and mast cell stabilizer, or known as chromoglycate. So how do we give these medications? There is this asthma step-up therapy, which is used in the management of chronic asthma. So there are 5 steps. So we start at the step most appropriate to the severity of the patient, and we move upwards if needed or downwards if the control is good for more than 3 months. So step 1 would be occasional short-acting inhaled beta agonists like salbutamol, required for symptom relief during acute attacks. If it is used more than once daily or there are nighttime symptoms, we go to step 2. So step 2 would be adding a standard dose of inhaled steroid, for example beclomethasone, 200 mcg per day. Or we can also start at the dose which is appropriate for the disease severity, so it depends on the patient as well. Step 3, we need to add a long-acting beta agonist, which is salmeterol, by inhaler. If it benefits but is still inadequate control, we continue and also increase the dose of the beclomethasone to 800. If there is no effect, we stop this LABA and increase the beclomethasone to 800. Step 4, we can consider trials of beclomethasone up to 2000 mcg per day, or modified release oral theophylline, or beta agonist, or oral leukotriene receptor antagonist. Step 5, which is the final step, we can add regular oral prednisolone and also refer for specialist input since it is severe and poorly controlled asthma. That is all for this video. Thank you.